My talk will be basically on the myths and facts regarding the process of obtaining consent. Consent forms are nowadays available online with all the societies, AIOS, DOS, MOS, even in Hindi, Marathi, English, everything. You can always have it. But that is the process of obtaining consents. I would like to stress how we should go about it. So, informed consent, the law as it stands today, essential guidelines. What is the problem? Why patients decide to sue or file complaints? Relevance of a consent form, conveying caring attitudes with information, process of informed consent, and integrating the process and the form. As a starting point, it is necessary for us ophthalmologists to understand some of the basic legal fundamentals behind the consent law. As we all know, informed consent is defined as a process for getting permission towards medical treatment by a patient, granted in full knowledge of the possible consequences, risk, and benefit. Most Western countries are shifting towards adapting the patient viewpoint as against our reasonable physician viewpoint that we practice in India. So what is this? Patient viewpoint means the type of information should be disclosed to a patient that a reasonable person in patient's position would want to know in similar circumstances. The law clearly states that ophthalmologists have a non-deligible duty. It is a non-deligible duty. You cannot say, okay, my sister will be explaining, my technician will be explaining. You cannot delegate. Ultimately, you have to have 1 word, 2 word, 3 word, or half an hour with the patient before he signs the consent. So it's your non-deligible duty. You cannot say in the court of law कि मैंने तो बात ही नहीं किया था patient से, तो हमारी sister लेती है consent ward में. It cannot be like that. And you have to discuss the diagnosis, the nature and purpose of treatment, risk and benefit of proposed treatment, alternative methods of treatment, and risk and benefit of no treatment. All these possibilities have to be covered in your pre-consent counseling. Almost 95% of our ophthalmic negligence court cases that reach the court are decided in favor of ophthalmologists. Then the question arises why the patient felt so aggrieved that he went to the court when the doctor was right, but the patient felt aggrieved. What was the point? So why were such actions filed and without any sufficient legal grounds? The simple answer is that many patients sue regardless because they are surprised by this clinical outcome and they are angry with the provider or ophthalmologist who they strongly believe to have caused the harm. General assumption that most patients are motivated by greedy or predatory lawyers or relatives are unproved and usually not the fact. All data in literature suggest that patients or their family members who file court cases or claim regarding medical negligence strongly believe ophthalmologists did not warn them about the potential medical problems following the treatment and doctors tried to mislead them. Relevance of consent form. In such a scenario when such emotional factors are involved, even the best constructed legal consent forms become virtually powerless to forestall litigation. Yet a consent form coupled with the patient's perception that important clinical information was personally conveyed by a caring physician could help to prevent the many unexpected medical outcomes that occur from reaching the courts. A physician who carelessly acknowledges clinical uncertainty and empathizes with the patient's wish for positive outcome forms a therapeutic alliance or bond which many patients will pursue as a caring and personal attitude. Such interaction prevents informed consent activities from becoming mere episodic events which occur only when someone signs the form. So, signing the consent form is not the only event that is of importance. Right from when the patient first visits your hospital or registration counter, from there itself the process of taking consent begins. That is the first encounter of patient with the operative and post-operative treatment phase, and forms and signatures are merely an end stage culmination of the process and not the focus of it. So we have to integrate the process of obtaining consent and the consent form. Informed consent is still regarded in many ophthalmic practices as a discrete legal event rather than interactive process. It is important to change this mindset. Hospital support staff such as nurses, paramedical personnel and administrative assistants must be first encouraged to shift their focus from paperwork of consent to the ongoing process that is happening. Documentation is important but should not be the sole objective during this phase of the process. When possible, start the consent process early, sharing the pertinent information. This doesn't mean an immediate recitation of risk, benefit and alternatives to the patient, but rather an interactive exchange of relevant information designed to understand the pertinent clinical issues and mutually explore clinical expectations. A large number of patients and their families perceived that the doctors would not talk to them or answer their questions. Many believed that no one in the hospital was listening to them. Try to make arrangements to have family members present and included when discussing the patient disease and the planned medical treatment or surgery. During initial or subsequent visit, introduce the consent form and explain its procedure. Clarify for the patient that the form is intended to help both the patient as well as ophthalmologist. Important facts which matter to the patient have been discussed and are understood. Be frank and honest about clinical uncertainties, but don't overcompensate by avoiding potential benefits or treatment either. Give the patient a copy of the form or documentation, either before or after it is signed. Contrary to our belief of many doctors, adversarial note is intoned not when the form is being signed, but when a copy is not made available or graciously offered to the patient. So patient or relatives ask us a copy of that consent form and we say no, it is our hospital record, we won't be giving, we won't share. That itself creates doubts in their mind. You can always give it a copy. There are many studies in US also, UK also, where it has been conclusively proved that there is no adverse outcome if you give to the patient the form. I will just wind up. If patient appears troubled over the risk and uncertainties of treatment, empathize with him, accept their ultimate decision, and if the consent process was properly handled as described, there should be no animosity. When possible, make contemporaneous note in the patient's record during all phases of consent process, even if a form is used. Always put the counseling was done today at so and so time, and again patient comes back for taking a final appointment. Again you can put in that once more counseling was done. Model consent forms. The best way to document such consent forms are obviously model, and AIOC and MOS has done tremendous job in providing us with the consent forms. Each and every procedure you can download it by going on these sites. And if anybody has any questions or need more consent forms, you can always email us or any of the panelists, and we will be happy to provide you. Thank you so much for your patience.
Thank you, Dr. Viral, for wonderfully covering the topic. Very important, but from medical point of view, most of the patients and doctors, they are not that careful. I have seen most of the cases are just because the consent was not taken, or if at all taken, was not taken in proper format, and hence the litigation